Hello, everyone. Thank you so much for joining us tonight. This will be the last session of the Miami Pediatric Neurosurgery Zoomposium series that we've been running. And we want to thank everyone for tuning in over the last year to join us. Tonight, we are thrilled to have a fantastic panel of two experts on pediatric head injury. First up, we're going to have Dr. Duhaime speak. The title of her talk is "It's a Head Injured Child. Now What? Evidence Gaps in Decision Making in Pediatric Traumatic Brain Injury." She is a pediatric neurosurgeon at Mass General and an endowed professor of neurosurgery at Harvard Medical School, as well as she is now the associate director of the Mass General Center for the Environment and Health. So she'll focus on severe traumatic brain injury. And then after that, we will switch to Dr. Jillian Holtz, who is at the University of Miami with us. She is the director of the Kids Neuroscience Center, as well as the Concussion program, and a research professor in the Department of Neurosurgery and the Miami Project to Cure Paralysis. And she'll focus on the more mild traumatic brain injury and sports concussion, which is another hot topic in the field. We encourage all of you to type in your questions, as after the two talks, we'll have a discussion period, and we'd love to have a lot of questions from the audience that we can pose to our two panelists. So with that, we'll get started with Dr. Duhaime.
All right. Heather, is that visible?
Yep, we can see the slides.
Okay, terrific. Well, thanks everybody for joining us. And thank you, Heather and Shelley. And it's a pleasure to share the podium with a colleague and collaborator, Dr. Hutz. So this will kind of span the spectrum of traumatic brain injury. What we're going to talk about in this half hour is progress and gaps in pediatric traumatic brain injury, sort of across the board, not just on the severe end of the spectrum, but we'll leave most of the concussion spectrum injury discussion to my colleague. So what we're going to cover in this talk is how do we get new data to inform our head injury management? And in order to cover that, we'll talk about updates on two large natural history comparative effectiveness studies. First, the TRACK TBI study, and the other, the ADAPT study. We'll go over what those are and what they've learned so far. And we'll talk a little bit about large animal translational insights as another way to fill gaps in our knowledge of how to manage pediatric traumatic brain injury. We'll talk about some clinical trends in the management of pediatric traumatic brain injury. As mentioned, the concussion spectrum will be covered in the second talk. And we'll talk about some critical care management trends and some gaps, particularly with specific lesion types, things that I hope some of you in this audience may tackle in your academic and research careers, because they're areas where we still have a lot to learn. We'll talk about some clinical examples in a particular interest of mine, which is the role of plasticity in determining the outcome from traumatic brain injury. And I have no disclosures or conflicts to disclose. So when you're faced with a child in the intensive care unit and they start asking you, what do I do with this kid? Do you want mannitol? Do you want hypertonic saline? Do you want an intracranial pressure monitor? Should we give Lasix? Should we give, whatever? And you are trying to figure out what to do for this kid. How do you go about it? Well, you can do a literature search on something specific, but oftentimes you're not going to find things that are specific. The data are going to be glommed together with many different types of patients, many different ages of patients, and many different types of injuries. So it's hard to figure out from the literature what to do for the kid in front of you right now. You can do what you saw somebody else do. That's always a safe bet, especially if you're in training. And then you can see if there are some sort of guidelines to help you. And most of the people probably watching know that there are guidelines. There have been guidelines put together for many different conditions, including concussion, as our second speaker will talk about. And guidelines are an attempt, as you all know, to apply large bases of evidence to our decision-making. The problem is that guidelines are only really as good as the data that goes into making them. And there have been many methodologies to try to make guidelines more and more strict in terms of whether the data that you are touting for a particular problem really applies because it was gathered on similar types of patients without bias. But this can be really hard. And so in one of the more commonly promulgated iterations of guidelines for traumatic brain injury on the severe end of the spectrum in children is this one that comes out from Pat Kahanik's group every few years. And this one has 22 recommendations, but despite the fact the authors tried really hard and put enormous amounts of effort in this with wonderful resources of large data analysis and library searches and so forth, there is not a single class 1 recommendation. There are only 3 class 2 recommendations, and 19 of the recommendations are at class 3 or option level. And what that means is that for most of the children we care for, the evidence for what's the best thing to do for them simply is lacking. Well, why is that? There have been thousands and thousands and thousands of clinical trials in animal models, in all kinds of models of head injury that have shown wonderful effects of pharmaceutical and other kinds of agents on improving the outcome from traumatic brain injury, whether it's clinical outcomes, a rat does better on rotorod or motor tests or memory tests. It can be a histologic outcome. There's a smaller area of damage. It can be biomarker outcome. It can be imaging outcome with all different kinds of outcome measures. Many, many different drugs have been shown to be effective in rats. So for rats and mice, trauma, not a problem. There's a lot of things you can use, but not a single one, with maybe one exception in the chronic stage, has translated to be effective to human trials, never mind pediatric trials. And why might that be? Well, when you think of what goes into the pie of factors that determines the outcome after a head injury, if you're a rodent and you're in a clinical trial with hundreds and hundreds, if not thousands of other rodents, you're all genetically similar. Your injuries are all the same. The care you get after your injury is all homogeneous. The food you get, the light and day cycles, the emotional stress, you name it, all of these things make up a really homogeneous part of the pie. Whereas if there is an effect on the injury cascades, that is the molecular sequence of events that is initiated but not completed at the time of injury, and if you have a medication that can make an impact on those, it's going to be a significantly bigger part of your overall outcome determining pie than if you're a human. Because if you're a human, all of those variable factors of your host and injury factors that vary from one patient to another, including age, which is our topic here, is going to be so enormous that any effect of a drug is going to be active only on a very small slice of your pie, and that effect is going to be washed out. So this is the reason that so many things work in rodents and have not worked in humans. And then when you add pediatrics into the pot, which is a entirely different set of factors, it can be really impossible to find these events. So the National Institutes of Health recognized that there were so many pharmaceutical trials, big trials, that had been proven in animal trials and failed to translate despite very strong efforts into humans, that they put together, hand-wringing workshops, which is, what should happen when things don't work. And what came out of this was an effort that many of us were involved in, some people perhaps on this call, and sort of our fearless leader here, Jeff Manley at UCSF, really took the reins here. And the thinking that we all had was, part of the problem was if we just classified or categorized the injuries better, and then you used a pharmaceutical agent on that injury that matched the kind of injury type that it had gotten in the animal phase, you might have a better shot. So if you treated human contusions with a drug that worked in contusions in rats, and if you treated subarachnoid hemorrhage in a drug that had worked on subarachnoid hemorrhage in rats, for example, maybe you'd have a better shot. And so a lot of effort went into trying to figure out how would you go about doing this. The problem for kids is that there are some injury patterns that only happen at specific ages, and in the scheme of head injury, they're pretty rare. So this is a classic fall from height. This kid fell from a second-story window, is a baby, so has a malleable skull that cracks, and sweeps in and literally tears or lacerates the cortex. This kind of brain laceration from a malleable skull, while adults can get brain lacerations, this particular pattern is pretty unique to very young children. This is a child whose head was run over in the driveway by an automobile. Again, a classic pediatric injury, a crush injury with strains to the posterior fossa and other places. This injury, you can have crush injuries in adults, but it's not quite the same flavor of crush injury. Here's a child with another sort of a crush injury, a large object falling on the head. These are all child abuse injuries, which are really very different and poorly understood. We're going to talk about them a little bit later as well. So treatment trials for these uncommon but important to us in pediatric neurosurgery types of injury are really statistically going to be very difficult. So are there other ways that you can get data to inform your management other than a prospective treatment trial? And what came out of these efforts that Jeff Manley and others were involved in from the NIH revisitation of why we weren't really getting anywhere with pharmaceuticals was this idea of creating, with large data technologies that had come online during this time, big natural history and comparative effectiveness studies. So here, as in other illnesses that you all treat, the idea was with large data, we now have the ability to store and analyze enormous volumes of data that can look backwards, even if people aren't told how to treat patients, and extract some of these factors that will allow us to retrospectively stratify patients into different groups and say, well, gee, this worked for this group, but it didn't work for this group. So you go backwards from your large data set and try to figure out what treatments had the best effect in what types of patients. So it's getting at it a different way. And out of that effort came two big efforts: the TRACK TBI effort, which stands, they all have to stand for something, Transforming Research and Acquiring Clinical Knowledge in Traumatic Brain Injury. This trial enrolled all ages from newborns all the way up to, in the 90s. I don't think we have anybody over their 90s. All severities of injury, from the mildest to the, moribund. They all had clinical imaging, and this trial has now enrolled over 3,500 patients, including two different types of controls, but only a small number of kids because it was only a pilot for kids. And both the second speaker and I were involved in this pilot for kids that we'll talk a little bit about. The second trial, which is probably more, has a higher yield for most of you on this sort of video, is the ADAPT trial, the Approaches and Decisions for Acute Pediatric TBI. This one focused on the other end of the spectrum, only kids that were seriously enough injured to be in an intensive care unit with an intracranial pressure monitor. And the goal was to enroll 1,000 kids in multiple centers. And that was a real undertaking. And the organizers are to be congratulated because they carried this off and enrolled those kids within a couple of years. It was quite a feat. So what do we have so far from these comparative effectiveness approaches? From ADAPT, we are still waiting for most of the results. They're still being analyzed. Some of the things that have come out so far is that there's a lot of variation among sites in management of something as common as seizure. So if you are called to care for a child in your PICU or in your ED and they say, should I give anticonvulsants? The fact you don't know, it's not surprising, because these kinds of decisions all over the country at different sites by different people are made in different ways. Another thing that came out of ADAPT fairly early on, as they started to analyze their very large data set, was that contrary to what many people were taught, is that age does not affect mortality. If you take out the child abuse kids, which tend to be young and skew the population, if you remove them, because they really are a different type of injury in most cases, being young does not increase your mortality, which was a thought in the past. Now, the practical questions about what works best, which anticonvulsants in which patients, which hyperosmolar therapies, does ventriculostomy help? These are still being analyzed, and we don't have the data out yet, but hopefully that will be coming out before long. So let's go to track TBI. Fewer children, larger number of patients, very big data set, lots of data on physiology, biomarkers, imaging, very fancy imaging, very detailed neuropsych outcomes, and many other elements. And so the milder end of the spectrum, or so-called mild TBI, GCS 13 to 15, we're a little bit trying to get away from these terms, but have not really been able to. That's going to be covered more in the second talk. For TBI overall, that is all the patients with TBI, including the severely injured patients, here's what was found so far. 50% had no patient education or follow-up. That is 50% of patients that showed up in a hospital, whether they went home from the hospital, were admitted to the ICU, or whatever happened to them, many of them never had any follow-up with any clinician, which is really kind of surprising and points to a failure in our whole management scheme. It also has been shown by the track people and others that patients getting any follow-up do better with their symptoms than patients who get no follow-up. Just having that reassurance can be extremely helpful. Pre-morbid factors. It turns out these play a bigger role than most people thought. And I'm going to tell you a little bit about that in kids. And serum biomarkers, this has been one of the major things that have come out of the track study, is that there are predictive biomarkers, and more can we talked about that in the question and answer session. Now, other findings. Of patients with moderate and to severe traumatic brain injury, one of the things that was found from the track study so far, because it's extended out to 7 years after injury now, is that people continue to improve at and well beyond 12 months. I remember being taught as a resident that adults tended to level off and stop improving after 6 months, and children maybe a year, maybe up to 2 or 3 years. But this has been shown when you actually follow the patients for longer, they can continue to get better. But a subset show a late decline, and that's very interesting as to why that would be. Now, this is adults, not kids, although our adult cohort includes 17-year-olds. Polytrauma gives you worse disability, not terribly surprising. And a lot came out of track so far about methodology improvements, quicker, cheaper, better ways to do clinical trials in anticipation of doing actual treatment trials. There have been a couple of comparative effectiveness research results. None of these are relevant to children quite yet. What we found in the pediatric group was, and this was between Miami's group and ours, is that the pre-morbid factors had a bigger role than we expected. I thought if you were going to look at what predicted a child's outcome, it would be what was on their imaging. That is, if they had, lots of spots and dots on their imaging, they would have a worse outcome. That's true for the really seriously injured kids, the kids with prolonged coma, kids that needed, surgery, had lots of damage. But in the kids who regained consciousness within 24 hours, no matter what their imaging findings were, the thing that predicted how they did, and this is measured by what their parents thought they were like, which is considered a pretty reliable way at 3 months and 6 months. The thing that predicted how kids were was not their imaging. It was what they were like before they were injured. So the pre-morbid factors, if the kid has a learning disability or an emotional fragility for some reason, or cognitive difficulties, life stresses, all these sorts of things, these play into their outcome much more heavily than we thought previously, even more than the imaging predicted. And conversely, we found that kids who seemed to have a lot beforehand on the ball, they were smart kids, they had really supportive families, social determinants of health were all in their favor. These kids seem to do better. And this may be this idea of cognitive reserve, but what was most surprising is that the host factors played as big a role as what we did and what their actual injury looked like on imaging. So one of the questions we've worked on in my laboratory over the years is whether or not the effect of age plays a role in how the brain responds to injury. So does the brain respond differently to injury depending on the age at which it's occurred? And does this vary among types of injury and types of patients? And as pediatric neurosurgeons, you have a front row seat to how the brain responds and recovers. And, it varies over time because you watch these kids grow up. And our efforts have been to try to take what we see from that front row seat and apply it to, in our case, large animal models largely. And to determine what goes into the ultimate injury, I was raised thinking that the forces determine the injury, and that here we are as surgeons, we can prevent secondary injury. We can give treatments to try to protect tissue that is injured but not all the way damaged. But what I've come to realize is that the host factors that influence these things, as well as the repair and recovery, particularly plasticity, play a very big role. And these are interesting from an academic point of view for people who are interested in head injury. So my first clue about this was when I was a junior attending and we had a child who should have been dead. She came in dead, actually. She had received a point blank gunshot wound to the forehead with powder burns. And this bullet went right through her head, through the posterior fossa. So it crossed the spheres of the cranium, both left to right and front to back, came out the back of her head. And she came in pulseless, apneic, and had been that way for 20 minutes. And I told them to call the code because once I saw that this bullet went right through, we could tell that on a skull x-ray. We didn't have to take her to CAT scan for that. I just thought this was a non-survivable injury. Well, the punchline is kids surprise you. This child also had a very dedicated family who wanted everything done. She cracked her skull in many locations, so she did not have high intracranial pressure because she basically auto-decompressed. And ultimately, I had to cover this up for all these images for privacy, but this child regained the ability to walk and talk. She had some permanent cranial nerve deficits. But this just shows that kids don't follow the same rules about necessary morbidity as adults. This is another child that I learned from who was struck in the head by a truck. And he had this classic pediatric injury of a force wave through the low frontal region, through the skull base, through the hypothalamus, through the pituitary stalk with pituitary stalk injury, into the midbrain with dilated pupils on the basis of a direct midbrain force wave. And, lots of bifrontal damage. I just thought this child was going to be terrible. And his family, was dedicated. They took him home. They didn't even send him to inpatient rehab. Sorry, Jillian. And they just treated him at home round the clock. And he made an astonishing recovery. Now, we all have exceptions like that. But the point is, kids have plasticity, it appears, that adults don't. And it's part of what makes our jobs so gratifying. Now, it doesn't mean they're unscathed, but it means that they can recover functions that people can't in the older age. So we've spent a lot of years trying to figure out what is it about the brain when it's immature that is different. And what we have found to put a lot of research into a short stint, the immature brain actually is more resistant to focal mechanical trauma when it's very young, in the infant stage. It may be slightly more sensitive to rotational injury when it's older, like the adolescent age. But in the immature stage, the most immature stage, to mechanical deformation of the cortical surface itself, like a contusional injury, the immature brain is very resistant to that. So little children will do better with that and end up with a smaller injury for the same degree of force. In addition, we've been interested in repair, neurogenesis, and plasticity, and we have found through our human patients and through our animals that the brain does try to fix itself. It tries to send things out from the subventricular zone into the surrounding damaged area, but those neurons appear to get stuck, and they may be what causes intractable epilepsy in some of these kids. When we follow in animal models, what happens to those cells, they tend to migrate to the frontal olfactory region, to the nucleus accumbens of all things. That's the part of your brain that teaches you what is rewarding, and to the hippocampus. But some of them get stuck because the white matter tracks that are there to guide them are disrupted. So whether this neurogenesis is good for you or maybe harms you still is an unanswered question. So using large animals like piglets, we've tried to also understand what's different about age electrically. And it turns out that the immature brain at certain ages has seizure potential that, like in children, is greater than it is at different ages. And the kinds of spread and the types of electrical activity that occurs at different ages may vary with age. And that has to do with the whole physiology of what's unfolding at that given time of development. So how does all this end up in trends in practical management? My own practice, because there isn't a lot to guide us, has been really designed on trying to spare the brain and facilitate maximizing the plasticity that children have. And these are some of the trends that have occurred over the last decade. Early decompression, when dangerous tissue shifts are anticipated, such as you're taking out the bone anyway to remove a clot or a large hemorrhagic contusion that needs to be evacuated, remove bone so that the brain can swell out instead of in. Now, this is controversial because there are a lot of side effects to this, and we can talk during the question and answer about it. Early ventriculostomy, the data from the ADAPT trial is not yet out. I've seen some of the preliminary data, but I am still a big fan of early ventriculostomy, again, in the right patient, a patient where dangerous tissue shift is anticipated. And that's not all patients with a GCS of a certain level or an ICP of a certain level. It depends on what that particular patient's particular anatomy and problem and injury type is. Also the age, because some ages we've learned swell more than others. I'm a fan of early and frequent MRI. I think it gives you more information about these other things. And multimodality monitoring, in my case, intracranial pressure monitoring, and virtually everybody with a significant injury gets EEG monitoring continuously. Attention to the perfusion side of the equation, especially in younger kids. Sedative choices have changed. I'm a fan of as low dose fentanyl as you can give to keep the child safe, but still be able to examine the child through the sedation. But dexmedetomidine has really changed our choices and allows us to wean kids earlier in many cases. Liberal anticonvulsant uses, because the risk-benefit ratio of levetiracetam in children of all ages is really very favorable. And because of all of this, we're fans of earlier weaning and wake up. So once you have an MRI that shows the dangerous tissue shifts are past, the cisterns are nicely open, and that can be seen so well on a T2 MRI. The swelling can be seen on flare. Any kind of ischemic injury can be seen on diffusion. Hemorrhage can be seen on susceptibility. So with all of this data and these data, we try to get the kids awake quickly, safely, and get them back to activities. Even for children who are not comatose and intubated, we try to get them back to activities. And again, the second speaker will speak more about this in the milder end of the spectrum. So this is just an example of why we are liberal users of levetiracetam or something similar. This child was sent back home from a local clinic several times, more than once. The mom brought the baby in with this behavior, and I know nobody on this video chat would miss this. The child was sent home with reflux, thinking that's what it was. See, the eyes are open. There's the child moving. Sorry, I was trying to move the eye cover. So one of the things that we have found is when children look like this and they look like they're doing something that could be seizures, one thing that's helpful to diagnose them is to give them a firm pinch of the trapezius and see if the baby changes the facial expression. This baby was a good example. The baby looked awake. Superficially, you saw the baby's moving, the eyes are opening. But when you pinch that trapezius, that baby's facial expression does not change and the baby doesn't cry. And this is a sign that the cortex is not working. The reason in this case it wasn't working is that the baby was in status. The baby was in status because the baby had a subdural hemorrhage and diffuse brain injury. And this is what the MRI looked like. This is really a patchy diffusion-related pattern of damage, and status was seen on the EEG. The baby had rib fractures, and the father ultimately confessed to having thrown the baby across the room on multiple occasions. And this is the long-term effect at age 6 years. So this baby could have been missed and re-injured if somebody hadn't picked up that that was a sick baby who was not having reflux, but in fact having seizures. Here's a 2-year-old who was found unresponsive at home and came in with a thin subdural. And really that there's a little bit of shift there, a little bit of mass effect, but the subdural is really small. But we have now taken to doing early decompressions on these. Here's an MRI that shows that that hemisphere is already starting to change. Here it is on day 3. The hemisphere turns dark on CAT scan. And over time, it swells up and swells out. And if you've left room, it'll swell out and it will spare that contralateral frontal lobe. So before, when you have the unilateral form of this hemispheric damage, most commonly, but not exclusively in child abuse, we would treat these medically, and they would almost always take out the contralateral frontal lobe in a little wedge. But since we have been decompressing them, it can spare that frontal lobe, and it's helpful to have at least one frontal lobe. So here's that same child at 2 years of age, as opposed to this child who was treated medically with that frontal lobe damaged. So because kids have plasticity, it's not just the youngest children do. Adolescents can as well, of course. Everybody has plasticity, including adults. But this was a great example of this. This is a youngster who was skateboarding down a hill by himself. He was on one of those skateboards where each foot has a different board, and he didn't have a helmet on. He was trying it out for the first time, and he went flying and crashed. And because he was going downhill, his velocity was high, and he just walloped his entire dominant hemisphere. Big skull fractures, lots of subdural, lots of contusions. This was his temporal lobe at surgery. Here's his Sylvian fissure, and he's right-handed. So this is his dominant temporal lobe, frontal lobe, just his entire language constellation here, just a mess. And it's just heartbreaking when you see this, because you know this kid is going to struggle. And a smart kid who this was, apparently, once we learned who he was a gifted child in school and a gifted musician. And here he is, you know, waking up, agitated, completely aphasic, globally aphasic, both expressive and receptive, put his skull back on. And I like this video to show, I showed this at the Marmaru lecture at the AANS. If anybody saw that, you will have seen it before. But it shows how he's still aphasic in this picture. But his parents were very concerned about his musical abilities. And, you know, how do you answer that? It turns out music is quite widely distributed in the brain. So you're just going to see how he's fooling around. He can't talk yet. This is the musical therapist, but watch his facial expression. I know it's a little hard to see through the.
Nice.
So he's goofing off, but you can see, even though he made a dramatic recovery and he can speak really quite fluently now, he still took a hit on his processing speed and other verbal things. But luckily, his music ability seems to be intact. And that's plasticity, because you know that temporal lobe did not recover. That's plasticity that made those functions come back. That was a big pulped temporal lobe, and that he had to work around that. Oops, sorry. Which is why, you know, why he has slowed processing speed, because to recover that, it was at the expense of speed. So in conclusion, comparative effectiveness research studies hold promise. We're all anxiously awaiting the results of the ADAPT trial, which really the investigators deserve a huge amount of credit for that. There's still data coming out of TRACK, 70 manuscripts so far, and more coming out every week. Translational research, like large animal models, can fill some gaps, but there's so much to learn that there's a lot of work to be done. But one of the things that's come out of all of this is that host factors, pre-morbid problems, cognitive reserve really play a big role. And plasticity also plays a role in outcome. We don't fully understand yet how to enhance that. What if some of the medications we give actually hold back plasticity? We don't know, and that's where research will be needed. And this is especially true for pediatric patients. So I think as a clinician, you can enjoy the recovery because it really is gratifying, but respect that there are sequelae left, that recovery and plasticity may be at the expense of certain functions, and we can't lose sight of that and just say how great the kids look superficially, because they still do struggle, and they look to us as the neurosurgeon to help them with that and to guide them and guide the family in what comes next as they recover over years, really. I have many collaborators that have helped with all of this, and I will, with that, turn this back to my colleagues.
Thank you so much. That was wonderful. So I'd encourage the audience, please type in your questions. Once we finish the second talk, we'll do our question and discussion session. So please start typing away. And with that, we'll turn it over to Dr. Hutz, who's going to talk about our more mild and moderate type traumatic brain injuries.
Great. Can everybody see my screen?
Yep, shows up perfectly.
Okay, perfect. Just want to thank my colleague, of course, Dr. McCrae, and wow, what a special treat to be on the same panel and podium with Tina, Dr. Duhaime. It's always great to share our thoughts. We've worked a lot together, and it's great that some of the work that we've done with TRAC is getting out there. Of course, we always want more, so you know, we're going to be always looking for other pediatric sites, and just always, if you're interested, you know, either reach out to her or Dr. McCrae, because there's always stuff coming up that we're looking for some really good pediatric sites for different studies. Anyway, I've been doing this a long time, and I've been at the University of Miami since 1992, and they opened the doors of the Ryder Trauma Center. And, you know, when you're in a place for a long time, you get, you know, to be known by, I guess, a lot of people in the community, and you meet a lot of friends, and you get to sort of work with a lot of companies and different groups. So we've had the pleasure of doing that all these years. And, you know, from that, you learn a lot of experience. And the biggest word I say when people ask me about kids is the neuroplasticity. And I think Dr. Duhaime did a great job sort of giving you a little insight, in which most of you know that, you know, a lot of these kids do pretty well. And even in the concussion world, you know, my sweet spot is all high school kids. We take care of about 60 public high schools and about 10 private, plus our own athletes here at the university. And, you know, seeing these kids, and even with the mild ones that can come in as train wrecks and have a lot of problems, you know, the first month post-injury, and then, you know, 4 weeks later, they're looking pretty good. You know, you don't see that that fast in an older population. So definitely, you know, that's on our side. And then just talking about the world of concussion and mild brain injury now, and it has been for the last, I'd say, 5 years or so. We're looking at somebody different than what they did maybe 10, 15 years ago. There's a lot of protocols in place, and people have to sort of watch what they're doing. There's a lot of liability. You know, the NFL has really led the way as far as, you know, what these colleges are doing, and what even down to high school and youth football does. So they look at the big guys, and the big guys have been really helpful to us in our community. They were one of the first NFL teams to really say, okay, listen, we're going to help the kids in our community. Plus, Florida does have like one of the highest drafts to the NFL. You know, every year these high school kids that make it to colleges, and then, you know, they get drafted. So, you know, they invest in their kids here, and the Dolphins do a really great job in the community, and they really help us with a lot of our baseline testing and workshops. So the concussion situation is still a brain injury. So, you know, when you talk to different colleagues, and more, we work with a multidisciplinary team, you're going to see in a minute, you know, it's a brain injury. And so you got to treat it like a brain injury. And it's still a force, and there's still, you know, acceleration, deceleration, and depending on the force, you know, you're going to see different sequelae. And also, like, sort of, is it a linear? Is it more of a rotational hit? But I think, you know, we're pretty safe in saying that 80 to 90% of athletes recover pretty quickly within 7 to 14 days. And then it's the other group that come to our clinics, and we sort of see week after week. And those are the ones that are become challenging to us. Okay, why isn't my slide going forward? Let's see now.
Press the cursor in the middle of the screen, and then you'll be able to move it.
There you go. You're brilliant. Thanks, Ignacio.
No problem.
Anyway, so what happened, you know, in 2009, we had this one case in Seattle that really led the way for the seriousness of what was going to happen with youth concussion legislation. And all of you know from different states around the country that all of us have this youth concussion legislation. It's pretty similar, and it really takes kids that are under 18 and gives them some protection. And basically what it really says, and most states are the same, is that, you know, we have to inform and educate coaches, trainers, and the athletes and parents about all of this. There has to be a signed informed consent by parents that they understand the risk. Also, removal from play of any athlete that has any kind of concussive event in play or practice, or a suspected concussion. You know, helmets are taken, or they're asked to sort of come off the field by trained people that hopefully know what they're doing. And then it has to be really, the key here is cleared by a healthcare professional. Now, in every state, there's different healthcare professionals that have been able to, you know, get through the legislation. Here in the state of Florida, it's an MD or DO. We don't have, you know, some of these other allied healthcare providers that they may have in other states clear somebody to return to play. So here in the state of Florida, it has to be an MD and DO. So, you know, the liability thing has helped us get mandates done here, especially in Dade County, because, you know, people don't want to be in court. They don't want to lose their teams. They don't want to, you know, have lawsuits, and the whole, you know, system goes down if that happens. So we see a lot better, you know, sort of ability for these coaches and athletic trainers to say, okay, you know, this is what I need to know. This is what I need. My skill level has to be if I'm going to be out there with these athletes. And so I think this has helped us in the long run to, you know, get kids being played safer and being watched closer. Of course, you know, the signs and symptoms, you know, we see that there's that daziness, there's the clumsily moving. Some kids, you know, throw up, they answer questions slowly, they're processing things slowly. The whole loss of consciousness is not a mandatory thing for concussion. You do not have to have an LOC. And then, you know, sometimes you see the personality change, and they may be walking in the wrong direction. The symptoms is what we treat, right? So if they show up in your clinic, you're treating headaches, you're treating the nauseousness, dizzy, balance problems, double vision, sensitivity, you know, lighter noise. Sometimes they tell you that they're feeling really foggy, they're having trouble getting their work done in school, not sleeping. Sleeping's a big one. So if they're not sleeping, of course, everything's gonna sort of go downhill. And then, you know, some of these cognitive problems and academic problems. You know, the most common thing we see are headaches. And the challenging thing about this is, you know, you would think that a 14-year-old that comes into your clinic is just talking to you now about the current headache they have. But, you know, come to know it, that a lot of these kids come in with pre-morbid, of course, the ADHD. They have, some of them have headaches from before. Some of them have some, you know, very soft signs of other neurological issues, some learning problems. So all of this has to be taken into consideration when, you know, you're treating their headaches. And, you know, a lot of parents don't want to be giving their kids drugs. So we go the supplement route with a lot of these kids, the magnesium, the riboflavin. And, you know, sometimes that works for a couple of weeks, but, you know, you have to be able to classify these headaches and sort of treat them accordingly. And then the other thing is, because we're, you know, in a position where we have a lot of research going on, I'm so fortunate to work with one of our ENT docs, Michael Hoffer, who's been doing some research with these goggles, and they're trying to get them small enough that maybe they can be on the sideline for rapid eye movement. And we have to remember that sometimes these injuries are more vestibular in nature, coming from the ear system and the balance system. So a lot of the times we'll send, you know, if they're really complaining of dizziness and feeling nauseous and sort of the room spinning type thing, they definitely go over to see the guys at ENT. So, you know, the approach really is pharmacological. You know, do we really need drugs to treat these kids? If most of them get better pretty fast, usually, you know, it's time and just acknowledgement that, yep, you're going to have these problems. Yep, let's do some accommodations for school and get you back slowly. You know, sometimes they do need the vestibular therapy. And of course, it's still rest, but not in a dark room, not sleeping in bed all day. You know, we want these kids moving and back to their schedules. So because we see so many kids in about, I guess, 2012, when we got the legislation passed and we were going these county-wide programs and managing most of the high schools in our counties, we come up with an injury prevention model. So we have a lot of injury prevention programs that we do. We have a walk safe, bike safe, skate safe program. And the basis of all these are like 5E programs with evaluation in whether it's engineering, enforcement, education. And so, we took the same model system and put it into our concussion work. So it's really a 3E system where we do a lot of education up front. We do a lot of execution and implementation of a 6-step protocol, and then we evaluate this. And so it's not me, I'm a really good cheerleader, like I tell people, but without the pom-poms. But the team approach is like the way to go, because everybody's involved here, whether it's the athlete, the parent, the coach, the trainer, of course, the clinic people. We're a whole team, and we all have to work together now to get this kid back into play. So we have a really interesting, diverse team. We have actually, a couple docs now that are really managing these kids for us. We have a sports neurologist, actually a critical care guy that like really played soccer most of his life, is a musician, and just is really loving taking care of these kids in a clinic. There's Dr. Hoffer, our ENT neuropsychologist, and this guy here, Ray, is an ex-NFL football player, played for the Patriots, who I'm so lucky to have to do all our outreach for the last 5 years. He goes out to all the schools and does the training. And then Gabriel, our clinical coordinator. So we have a really solid team of folks that really help us get these kids in and out and back to play. But it's all really starts with education. And as I said, everybody has to be educated. And I always say this, that, why would you send your kid to a pool without a lifeguard? Well, you shouldn't be sending your kid to an ice rink, soccer field, or a football field, or wherever they're going to go, basketball, volleyball, because you need people that are trained and certified to make sure they manage your kids properly from an injury. And parents need to ask about that. And I'm pretty certain that, a lot of parents just think, well, I dropped my kid off at, Pop Warner youth football, or, he's at high school playing volleyball. But, they got to ask these questions more, that they're certified people know what they're doing. The other thing about football, I always say to people, it's a numbers game. And, the big number of people that play football in this country are the youth. Then you got about 1 million kids playing high school, 73,000 playing college. And then really the pros are only about 1,600. So, I really am very careful when parents ask me about football and how dangerous it is, because I really don't want to persuade anybody from not going to a sport that really would either teach this kid life skill lessons, or maybe have a skill that would better his life and get him to college. So, it's a very fine balance of, when people ask about, how dangerous some of these contact sports are. And I just always go back to that. I always review the literature, flag versus tackle. And you have to know that the injuries are more than, in flag than you do see in tackle. It's the whole body. You can definitely get some head injuries in flag. And it's funny that, I always said that I thought flag, well, not so much funny, but just a reality that flag, is just pretty dangerous, because we have girls now playing flag football in high school. So now young girls play on flag football teams. They have teams. And the year before COVID, we saw so many young women that came in from high schools that were either cheerleaders that are flyers and get dropped, or these young girls now that play flag football. And, I wrote a couple papers about this, and it's on our website at uconcussion.com if you want to take a look. The other thing is about helmets. A lot of good marketing. We all know that helmets do not prevent anybody from having, concussions or brain injury. It's another coating. So maybe, you might get lucky not to have a skull fracture. But, it's a big issue because they're not worn properly, they're not done up properly, they're not fitted properly. And so what we spend a lot of time on in the beginning of the year when we do our workshop is how to fit a helmet properly, because I think it makes a difference. So again, gatekeepers are really the athletic trainers. We're so lucky here in Dade County that they work for the school board. In other counties, some of them are consultants, some of them don't have any. So here in Dade, they're just part of the school board. They get paid by the school board. There's no conflict of interest. And so we're very lucky here that we get to train these professionals every year. And the other thing we did just to make this all standardized and streamlined was we came up with a 6-step protocol. And so we do use baseline testing. I think it's better to have something to compare Johnny to, which is Johnny. I think, if you can compare yourself to yourself over time, I think that's much better than comparing me to, a statistic. The other thing is about, getting these kids into a system, getting them identified, getting them seen on the sideline with assessment, bringing them to a clinic, and then having a return to play system that is gradual, and then actually collecting the data. And we have countywide surveillance systems, which I don't think anybody else really has, because we do manage 2 counties. And, the data that we have here is really important because we have contracts with the school boards, and we have to put these reports out, and we discuss injury prevention from these reports. So they're very helpful. So we do use impact still. I think it's a good way to start the conversation with an athlete that this is serious when we sit down and they have baseline testing, and then they're retested again, within the 72 hours. That's our protocol. The other thing is coming to the clinic, they have the opportunity to be seen by experts and a multidisciplinary team. And this is very acute. I have people that answer a phone number that is going directly to people that make appointments for our clinics. We have 3 clinics a week and 1 in Palm Beach County. And so we're very busy, and we're trying to get these kids in as soon as possible so they have an opportunity not to miss too many games, get them seen, don't get them upset about not being playing, missing their teammates, which takes them down other rabbit holes. So I just want to make sure that we get these kids in and we see them quickly. The other thing is, we don't put anybody back to play anymore without getting them little exertional activities. So before we used to just say, okay, go back, here's your note, and you can go back to the game tomorrow. We don't do that anymore. We find that going back gradually. So if they haven't played for 3 weeks, getting them to do some low exertion first, some light jogging, stationary bike, and then maybe some drills the next day, and then maybe some, sprints. That sort of gets them back. And then if they don't get to the point where they're asymptomatic and they're still having headaches, you back off and keep them, at a lower exertion. And the athletic trainers are trained to do this for us when they return. The other thing is, we have a surveillance system in RedCap. I'm looking for another platform now. We've been interviewing other vendors, but I think that, to have 35 data points on every concussion that happens in our high school program has given us an opportunity to really look at this group of kids quite well. So we have a lot of data. We've been doing this since about 2012, 2013. And of course, here in Dade County, it's football, football, football. And now we've got a lot of soccer, lacrosse. As I said, cheerleading is giving us some numbers now, flag football, but all this data is looked at monthly. The other thing is, with the impact testing, we're very sort of strict on, I have one research student that really sort of looks at this every week for me. And then we discuss sort of, what's going on with the numbers. Are we seeing post tests? Are the post tests matching how many kids that are coming to clinic? Because, with the protocol, we have a contract that, these kids have to be post tested if they're suspected of having a concussion. So I just want to make sure that all the numbers match up, and this really helps us do that. And then the other thing is just looking at some of our numbers here of, what athletic trainers are really good at filling out the surveillance reports. And, some are better than others. Some are really busy. But as you can see here, the big number in this first quarter was 58 athletes that were from football, 10 basketball, volleyball, and then the days out with football was 16.3 days, which is about 2 weeks. You had 53 athletes that were back to play in less than 28 days, which I would suspect. 14.2 days was the average. And then in the higher end, there was about 5 that were over 28 days and 38.2 days for football. I'm looking at here is the number of that these 5 were out. So the average. So this is very important because we look at this from a perspective of every sport, which gives us information for the school system of, what their numbers are of kids that are out, number of concussions they have also per school. And it's important that, we look at this monthly. The other thing is because we're such a football county, it's really important that we track the positions of the players. And so, we do this every year as well, just a window into, what positions seem to, have the number of highest concussions. And we wrote a paper about this too, you can take a look at. But, we do a lot of outreach. Ray goes out, sees a lot of kids. He does a lot better than I do going out to, athletes or trainers. So, this is where he spends most of his time. And like I was going to say that, we're looking for other platforms now. I think we can just do everything on our smartphone or mobile device now. And the athletic trainer finds it's a lot easier to have on the sideline than, a laptop or whatever. So we're looking at different vendors now to try and streamline our whole process to even make our data acquisition even better. And, a lot of papers, a lot of information over the years about, what we're seeing, how we're managing it, what we think can, be better and more of a model for other programs. And this is all at uconcussion.com. So I think I'm going to stop there. I know it was a quick and dirty, but happy to take any questions.
That was fantastic as well. Thank you so much. Once again, I'll ask the audience, you can type in your questions on the Q&A function. So please type in your questions. And until we have more audience questions, we'll get started with questions from myself and my colleague, Dr. Wang. So I'll start off with one question that came up for me while Dr. Duhaime was speaking, but I think is actually relevant to both talks. And I'd be curious the insight from both of you on this. The comment about how pre-morbid conditions affects recovery from injury really struck me. A lot of, particularly my teenage trauma patients, I know were troublesome teens before they had their trauma. One fell off a car because they were drinking, or they were out walking late at night from a party and then get struck by a car, things like that. And it definitely does complicate their recovery, return to school if they weren't going to school very well to begin with. So I'm curious from both of you, how should we address this? Do you have any insight into sort of additional things we should be doing when we take care of this population, whether they're severe traumatic brain injury or more mild traumatic brain injury?
Well, I can start with that one. It's a great question, Heather. I mean, I think that it's challenging for neurosurgeons to take this on as their shift because we're busy. We're in the operating room, we're on call, we're taking care of all kinds of problems. But oftentimes in my experience, again, this may be that I'm biased because I actually find trauma interesting and many people may not. To me, it's a microcosm of everything we do, which is why I was interested in the first place. It sort of encapsulates everything about neurosurgery as an almost as a natural experiment, if nothing else, in how the brain functions and recovers. But the point to be made is that these families oftentimes see the neurosurgeon as their head injury doctor. And they will continue to have needs that go well beyond your surgical care. And oftentimes, unless you're in a really well-organized place, like maybe in Jillian's place for concussion, they've got this entire team, but very few of us have around us an entire team of people for traumatic brain injury, where somebody other than the neurosurgeon is going to be identified in the subacute phases for your patients. Now, for patients that go to inpatient rehab, they may pick up a physiatry team that follows them long-term, but there's a huge, the kids with concussion, they're going to have Jillian and other people like her. Most places have some kind of concussion program. Those kids are all set. If they're athletes, they're all set. If you have a kid that has contusions, they didn't need inpatient rehab, or it was for a short time, they are going to say, especially if you did surgery on them, they are still going to see you as their doctor. And they're going to need somebody to run interference with them, whether that's your nurse practitioner or you call a physiatrist, to get these families and the kids some of the resources they need, because heaven knows they need them. And a lot of times, because they don't have a long leg cast on, people don't recognize that these kids have the same kind of problems that Jillian's concussion kids do, only worse, and they need help. And if they have behavioral problems and social determinant of health problems and family problems ahead of time, this head injury is not going to make it any better. I will say, before I cede the floor to Jillian and get her take on this, that I have, on rare occasion, I can think of 2 kids who actually got worse from head injuries, who were, real behavioral problems and so forth. And the parents felt that the kids got more mellow after the head injury and actually settled down and became more studious and did better in school. I think that's the rare exception. Jillian, what do you think?
Well, the return to learn is challenging. It's way more challenging than the return to play. And like you said, I think sports really gets a better look now if you have a group of people that are focused on, the concussion stuff, because then the kid will get seen and get help, from somebody on the team. But these kids that fall through the cracks, I agree with you. They're the ones that might have like a contusion or a small, bleed, and then they get discharged and they go back to school and they're failing, and they don't really have anybody except maybe, let's call that neurosurgeon we saw, when we were admitted, because you're right, they're the one that they'll call, but the resources aren't there. So it's challenging. And, I guess like if you had to have like brain injury, I always said, the state of Michigan at one point had the best resources. So you'd want to have one in Michigan. But now I think, if you're going to have these injuries, if they're sport related, you might get, more attention.
Heather and Shelley, is it okay if I ask Jillian a question?
Yeah, absolutely.
All right, so
Uh-oh.
Jillian,
That's the whole point, is discussion back and forth. So that
All
would
right.
be great.
perfect. So Jillian, you and I have duked this out before, and let's duke it out now because I haven't talked to you about it for a while. So this issue of cognitive rest, as you know, is a bugaboo of mine because I don't think your brain is any more metabolically active during calculus than it is during REM sleep. So I don't think it harms you. I don't think there's any neurophysiologic evidence it harms you. However, it may be that it doesn't feel good or that you can't do it, so it adds stress. So my opinion, do you feel, because the word out there still is like, if you exert your brain, it's going to make your recovery somehow worse on a physiologic basis. So help us out with what your current thinking is about that.
It's not so much the cognitive work, it's that they have a headache, right? Or they didn't sleep. So that's the problem. So that's what I try and get after first. Let's just make them feel that, they can go back to class and sit there. And even if they sit there for 20 minutes, but they don't have a headache, that is where I think you have to start. So I agree with you. I think that, taxing them on, reading something or, getting an assignment done will give you more time to do it. We'll tell you that you don't have to, hand it in today. You can hand it in a couple of days. But if that kid's having migrainous type headache, then you got a problem because you're going to be behind the 8 ball, whatever you do, unless you treat the headache.
Right. So I tell families it's similar to if you had mono or a bad viral illness, Epstein-Barr or something.
Or didn't you used to say if you had the flu? I think that's what you used to say, Tina.
Yeah, it probably was.
Right.
So the point is, you don't feel good. You shouldn't have to do schoolwork when you don't feel good. And, but it's not like it's going to harm your brain. And that's what families are afraid of. They, I see kids, my kids, that are in the on the floor is admitted and the kid's texting and the mother says, or don't put that phone away, it's going to hurt your brain. And I tell them, it's not going to hurt your brain, but if it gives him more of a headache or her more of a headache, she
Right.
shouldn't be doing it just because
Right.
she's not going to feel good. So we're all on the same page about that, it sounds like.
I think so.
Heather and Shelley, what do you think? What do you tell your patients? And what do your patients tell you? What's out there?
I mean, I sort of have a similar approach to you. I think I tell them that they should sort of go back to things slowly. I don't restrict them for a set amount of time from school. I tell them when they're feeling like they can go back to school, do a half day, see how that goes, go to a full day. And I try to get them back to activities. I do prioritize school over return to sports. I tell them go to school first and then start doing the athletics. But I tend to sort of tell them if they're getting a headache, they're probably doing a little too much, and they should back off if they're starting to get symptoms, but they can gradually return to things.
I'm on the same
How about
boat. I'm on the same boat because I feel like I tell the children that they know their body best. So if they're having a headache or post-concussive symptoms or any significant issues that's really hindering their performance or their quality of life, I definitely tell them to hold back on school or on return to sports. But I feel like if they're doing otherwise well and they're happy to go back to a little bit of part-time school and then eventually transition to full-time school, I have no problems with that.
But
So I think
the delicate balance is when you have a kid who has pre-morbid behavioral problems, anxiety, depression, whatever, and then you have the kid who uses the concussion as an excuse to avoid stuff. And I mean, the classic case that I saw of that was a kid who got hit in the head, I'm not kidding you, with a Nerf ball. And she stayed out of school for months. So Jillian, how do you handle those kids?
I was just answering a question, sorry. I just answered somebody's question about neuropsych. I think, most of the time, when we have kids that are, needing any other services, we try and get them for them. So this is what I was just answering, one of the questions there about neuropsych or psychology therapy or services, or if they've got some mental health issues. Sometimes, when these kids show up at your clinic, it's not as clean as, you think until you start talking to these kids, and then, everything unravels. This was just the the trigger that, brought on a lot of issues that now have to be addressed. So I don't know if I answered your question though.
No, but that's exactly it. And that, I think, is why a lot of neurosurgeons don't want to deal with these kids, because I don't know how it is in Miami, but where we are, the incidents, especially during COVID and now, of anxiety and depression and mental health issues in adolescents has been off the charts, like nothing I've ever seen. Like it used to be, every time that I checked the ED before I went home for the night to see what was in there, it'd be belly pain, blah, 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 hit by car, blah, 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 and now it's anxiety, depression, psych eval. I mean, like the majority of kids have those diagnoses. And then you add in, I mean, the head injuries are down, at least the sports head injuries, because of school, although now it's starting back up again.
Yeah.
But, neurosurgeons don't have the skills. And then as your reader who sent in the Q&A is asking, how do you get the kids mental health services? It is a real problem right now. It's a real bottleneck nationally. And so you add that into the head injury piece and it's a problem. One of the things for that listener or reader that I would say that was an attempt to come out of track, but a lot more work still needs to be done, are there ways to streamline these very lengthy neuropsych tests that are done now historically for kids with and adults with TBI? Can we, in fact, figure out which parts of those are really the relevant ones and make them a lot shorter? And they've made a lot of progress with that on the adult side. We still have work to do on the kid side. Jillian, is there any progress on that you know of?
The problem is that, to give these screenings doesn't give you much information. So when you talk to people like Mike McRae and some of these other experts in the field that really, this is what they spend their time doing and really know about, is that you have to have a certain number of items and questions to really see if there's a deficit there. And that's the problem where they say the screenings, doesn't really tell us that. So these in-depth assessments are still needed. I think more things are online now, and I know we did a lot through telemed, and we're still doing telemed, which, you can break it up and, go take a break and we'll see you in an hour sort of thing. But I don't think they've solved that question yet, Tina.
No, although we did find with the track data that the parents' description of the kids was pretty reliable. If
Yeah.
the parents thought the kids were having a problem, they usually were. And so, we also found that some classic measures and other classic measures were redundant. So maybe we didn't need to do all of it, but still work to be done.
I think the ones that I find the most challenging are the ones where there was a issue with the relationship between the parents and the kids before the trauma. Either the kid was sometimes running away from home, or the parent felt like the kid was out of control and didn't know how to control them. So, I'll regularly see kids who come back to clinic post a pretty significant head injury who, by all accounts, seem to be doing pretty great. They're actually not still having symptoms, and they'll admit that, but they're still not wanting to go to school or not wanting to behave or things like that. And the parent feels lost. And, I try to help them. I try to plug them in with neuropsych. I try to suggest they see a psychologist or a psychiatrist. But I think some of those are very challenging, figuring out how in the middle of your neurosurgery clinic, and I do stop everything and end up late for everyone else, you get them plugged into some of those resources. I think social work ends up being really needed as well.
Exactly. Are you guys in the neurosurgery world, or Jillian, are you in your concussion world seeing much effect of cannabis? Because we're seeing more kids get injured around the issue of cannabis use. I don't know if, I don't know if others are seeing this, but like you said, it can be a source of contention with the parents and the kids. The parents think the kids are, using more cannabis than they should be. There's school avoidance. And there's, car crashes and stuff like that. I don't know. Is anybody else seeing that?
Not yet.
I don't think we've seen as much of that. Some.
Yeah, Dr.
Maybe Miami is using other substances.
Yeah. So, sharing?
Pardon?
But Dr. Wang, do you want to go ahead with another question?
Yeah, absolutely. So Dr. Duheim, Dr. Hutz, I really enjoyed both of your talks. I think they were really good. And I have a couple of questions for both of you guys. So on the subject of the concussion clinics and all the work that Dr. Hutz is doing in the rehabilitation, the concussion world, I'm wondering, I consider myself very lucky to be working in Miami with Nicholas Children's Hospital, Holtz Children's Hospital, where we have very strong concussion clinic and experts. So my threshold for referral to a concussion after a mild head injury is actually quite low. But I think maybe in our audience may not have as readily access to concussion experts as we do here. So what do you think would be a threshold for referral to concussion clinic? For example, what kind of severity of the concussion or severity of sports-related close head injuries do you feel a concussion clinic would be, a follow-up would be necessary?
The problem is that you guys don't really follow these kids in your clinic. It's rare, this is what I've been told in Miami, that, maybe Heather or maybe you guys down at Children's would see, get a consult from the ER. I know there's somebody else who runs your concussion program who's a colleague of mine who tries to see some of these kids. But, if they're lucky enough to get referred to a clinic, then you'll see somebody who basically is complaining of symptoms. If the kid's not complaining of anything, you're never going to see them again because they're going to be back on the field, or back at doing what they were doing, or back with their friends, or back at school. So the thing is, it's, if you are seeing these kids in your clinic, refer them on if they have any symptoms, because, we can help sort of get those put aside faster. And if they are having cognitive issues or academic issues, we can also take care of those too. I mean, if you're not in Miami and you're not in Palm Beach or, in South Florida and you're somewhere else in the country, hopefully people on this webinar have programs close to them that they do have a team of experts that they can get, these kids to.
Yeah,
Thank you.
Shelley, I would say similar. I mean, we have a really nice concussion clinic that's extremely helpful, and I refer I don't refer everybody to it. I give virtually every family the contact information so that if they feel the need, or if referring docs call me, pediatricians, I give them the knowledge so that they can use it if they see the need. But I also will personally call for any of my own patients who are not a sports concussion, because the clinic is funded by and set up as a sports concussion clinic, but my colleagues will see those kids, but they need a little push to see them. So the kid that has a temporal lobe contusion, but isn't, in the ICU and isn't going to have inpatient rehab and didn't get the temporal lobe contusion playing sports, but fell off a bike or got clocked by somebody, who knows? Those kids don't have anything, but the same facilities that the concussion clinic is designed to, or the same services, those kids need them too. So if you do have places like that, if the listeners have places like that locally, don't think that they, oftentimes with a little nudge, they will see kids who are not just concussions.
Yep, sports, non-sports. We do that on Thursdays.
Wonderful. And then Dr. Duhaime, I really enjoyed your talk. I think one of the things that's very difficult as a neurosurgeon is trying to understand when to operate and when not to operate. We can read textbooks, we can read guidelines, but some people, just like your anecdotes, don't behave like textbooks. And you spoke very beautifully about plasticity in young children, and also about the role of early decompression and pretty aggressive medical care. So I'm wondering, how has your extensive research, in addition to your experience, changed your clinical practice? For example, compared to when you first started, how do you approach patients with severe head injuries now?
Thank you for that question. I mean, we all learn how to care for head injury from our mentors, basically, because there isn't any other good way to learn it, because there aren't a lot of data. So we learn, unfortunately, sort of by trial and error. And decision-making about surgery, as every other decision-making about surgery, is risks versus benefits. So these things come and go in trends. And I've heard people be very nervous about doing decompressions in young children. I don't think you usually need to do decompression in kids with, for example, child abuse injuries where both sides of the brain are totally destroyed already, and you can tell that early on. I don't think you probably help those kids, but any child, I guess not, I've come to the feeling that any child whose problem can be anticipated to be progressive swelling that is unlikely to be easily amenable to, kind of low tier medical management, you are going to sleep better, and everyone else is going to sleep better if that patient has room to swell over time. So if you feel that your risk side of that equation is acceptable, knowing, as many people have shown, that when you take the skull off and do a big decompression in a young child, there are a lot of complications. The risk of hydrocephalus is higher, the risk of wound problems, the risk of bone resorption, all of these things are high. But if you weigh that against a child who's going to herniate and destroy tissue that otherwise could have been salvaged and could have gone on to, recover and take advantage of that plasticity, that's the scale we're always trying to weigh. How does it change in light of my research? I think what's changed is the knowledge that swelling is age dependent, that swelling is maximal in young preschool age maturational level, at least, if it's the same in children, and it's very hard to test, you'd need thousands of children with the same injury, which no one has, and that swelling occurs later in adolescence. So what that has biased me in terms of surgical management is realizing that adolescents may peak their swelling not at that old 48 to 72 hours that we all were taught, but it may be a little later. It may be 4 or 5 days. And if you start withdrawing treatments and they have a swelling, what we call a swelling prone injury, we have an whole algorithm for that, and many things can be a swelling prone injury classified as that. If that's what you have, so that your biggest danger is tissue shift, and you're still on the upswing, then that's when, if you can get away with ventricular drainage or hyperosmolar therapy sufficiently, you're okay, but recognize that that peak is likely to be later, or has the potential to be later. So don't withdraw your aggressive treatments too soon. So I guess that's how I've changed my practice in response to some of our research, which is that some of these things change with age. That very exuberant preschool age swelling is the same time of life in humans and in large animals that we use, where your cerebral blood flow is maximal. And that's because that's what it's doing physiologically at that stage of maturation. So I just keep that in mind and always try to anticipate what's likely to happen next that could get us into trouble if you don't act aggressively up front. And you weigh that against, how could I get in trouble by being too aggressive?
Mm-hmm.
I have a follow-up question. A follow-up question on that with the children that you were giving as an example, a child abuse kid where you see unilateral injury and you're saying early decompression. Is early when they hit the door? Is early when you start to see some shift on imaging? Is early change in exam? Sort of at what point do you do that decompression if you think this is a child who may have trouble swelling?
Yep. So most of those kids have a very characteristic pattern. They come in unresponsive, already with some mass effect, with a small subdural, and already some early change, subtle in gray-white differentiation. And if I have a doubt, I'll get those kids very quickly into the MRI scanner and look for the diffusion, because the diffusion is what you see first. So if I have a kid unresponsive with a child abuse injury or an accidental, because occasionally that unilateral subdural pattern happens in accidental, but it's uncommon. But if I see that with mass effect and that hemispheric change, which is more sensitively seen on MRI, I would go right to OR then.
So it's really the ones that are coming in with a poor exam and that imaging finding. If their exam was a little better, you might watch.
Yes.
Okay.
Mm-hmm. And then you gave some examples about that little child who actually had a cardiac arrest with very significant head injury. So I'm wondering, in the future, for example, at what point in the patients that you treat, at what point do you say something is not salvageable? Like, with all of your research that you have now and with all of your experience, at what point would you say when a patient comes in either with a gunshot wound or a motor vehicle collision or a very significant NAT, do you say, okay, this patient I don't feel would benefit from any kind of medical treatment or surgical treatment?
Well, that particular kid, Shelley, I didn't think that kid should be treated. I told him to call the code. The only reason that kid was continued to be resuscitated is that the chairman of surgery overrode me, who came down to the ED and insisted that the team continue to resuscitate the child. And being honest, it was probably mostly, for the experience of doing it. And much to everyone's surprise, and I know Heather has been corresponding with me in the chat during this about a similar case that she's had, the kid survived. And the reason the kid probably survived is, again, that there was no real tissue shift because the skull base exploded from this trajectory, which is what happens in little kids with that kind of an injury. The surprising thing is that trajectory went through things that normally would cause fatality, but didn't, which is why kids can surprise you. And however, that said, I personally feel that it isn't up to me to decide, but what it is up to me to do is be as honest and forward projecting with families as I possibly can be. So, for example, children where both hemispheres are, you and I both know what we're talking about, massively damaged. Child abuse is one example, but I've seen it with kids whose heads are run over, with kids who have skied into trees, like massive force injuries where both hemispheres the thalami. To me, if your midbrain is wiped out on diffusion weighted image, that to me is a scale tipper. And I don't tell families what to do, but I will show them I'm sure you do the same. You show them the images and you try to project it for them as gently, but as honestly as you can. And some families go one way and some families go another. But many families are, in my experience, have been appreciative of your candor if you're gentle. And one of the things, this is not really talking about medical care so much as it is, how you handle families. I have found over the years that there are a couple of things that are extremely helpful to say to families. And one of the things that every family, you can see it affect them, is to say, he's not in pain. He's not awake. He can't hear you or feel you. He was unconscious from the moment that this occurred. He's not suffering and he's not in any pain. And families are so worried. And as a mother, you may know that they're worried that the kid is in there and awake and in pain and can't talk to them. That's what they worry about. That's what you emotionally worry about. And to be able to take that off of a parent allows them sometimes to step back a little bit and make these kinds of impossible decisions. Now, nobody can make these decisions logically. Nobody's in any logic situation in these circumstances. They're the worst thing that any parent could ever experience. And you share that, you recognize that, you acknowledge that. You wish that you could turn the clock back and it was 6 hours ago. And, if you're empathetic with that experience that they're going through, and you try to be honest, I usually have that big discussion on the next day. My first meeting with families with a bad head injury is usually to sit down and just start to give them introductions, give them some facts, explain what's going to happen, explain what we'll be looking for, answer their early questions. And then I give them time to think if I don't have to make, life or death decisions overnight. And the next day we sit down and go over it longer and sit down with the team and just take our time, go over images and so forth. And usually it's that second discussion where they've had a chance to think and they know what they need to know. So I guess my answer, it's a long way of answering, to say, I do have opinions, but they're not my opinions to have. We all, I'm sure it's naive to think we don't bias families, but bilateral devastating or deep injuries, thalamus, midbrain, with lots of cortex that's gone. And this is the other reason that I find MRI so extraordinarily helpful, because even though I know people will tell you diffusion weighted imaging is not always, irreversible and so forth, you and I know what a wiped out brain looks like from a trauma. And I think we have a pretty good sense of how likely it is that this patient will be affected in, trajectory altering ways from some of these images that we see. I usually don't make those decisions without an MRI. That
That's
answers
really helpful. The patient that I was messaging you about, actually, Shelley and I shared that patient, as did our colleague, John Ragib. So they had family discussion with all of us, and all of us thought the child was not going to do well. And he very much pleasantly surprised us, and we were all very happy to be wrong. We had done medical management to try to get him through.
But Heather, I would say that I don't need to tell you, you and Shelley both know this, and Jillian knows it too. A kid who comes back and surprises you and is walking and talking and looking good, every kid is cute when they're little, and they will do amazing things. It doesn't mean they're not going to have a long haul and a lifetime of difficulties,
Absolutely.
and it's hard for neurosurgeons because we're not there, we're not living it. So the challenge is, as Shelley said, the challenge is, how do you counsel people accurately and compassionately and not impose your own values on them. This is what is challenging about neurosurgery. Anybody can take out a subdural. That part is easy. It's all the stuff afterwards. And this is why a lot of neurosurgeons don't find it. They're like, give it to the critical care folks. I personally find watching these kids go through these processes and even watching and helping the family, I get just as much satisfaction about bringing a family through a tragedy as I do doing a good surgery, because how you handle that family will influence the rest of their lives.
Yeah.
And if you can take off some of their guilt, some of their angst, some of their nightmare, if you can help lift some of that justifiably, it'll make the difference for how the rest of their life goes. And I'm not trying to sound dramatic, but we've all been through this enough that it's absolutely true.
Yeah, no, and I think, that's also part of how we get through the day as neurosurgeons. We can't save everyone. And the ones that we can't save, I know I personally take some comfort from at least trying to help the family through a terrible tragedy.
And help them.
And I think the point about sort of how they are, you're right. Like this child, I'm trying to plug them in with neuropsych because I suspect that though he answers my neuro exam questions well, he probably is going to have some struggles with school and things like that down the line. So I think that raises the importance of the multidisciplinary team to help patients with head injury. It's not just the acute phase.
Wonderful. Very well said. Thank you so much both for your amazing talks. It was really, really good to hear both of your talks and to learn a lot today.
I think that was probably a good note to finish up on. So I definitely would like to thank both of you. Also, since this is our last Zoomposium session, I want to thank all of those who have tuned in for the sessions over the last year, as well as all of our speakers, panelists, moderators, the people that have joined in, and then our institutions, Holtz Children's Hospital in Jackson, Nicholas Children's, and the University of Miami Department of Neurosurgery for helping support us in this venture over the year. So thank you very much, everyone.
Thanks. Take care, everyone.
Thank you so much. Have a wonderful day. Take care.